August 25th of 2022. I'd like to call the meeting into order. At this point in time, we will have our attendance roll call. Ms. Thompson, call the roll.
Rhonda Allen. Here. Dr. Andrea Anthony. Here. Amber Brown. Here. Shay Crowell. Here. Holly Deering. Brian Gaither. Here. Mary Hickerson. Here. Lois Miller. Here. Alan McAdoo. Jeff Phillips. Present. Brian Runyon. Here. Shantae Sherrill. Here. Steve Spence. Here. Eric Tutobeni. Here. We have a quorum.
Well, we have a quorum, and well, let me like to point of order. I'd like to recognize our newest ex officio member, Mr. Michael Smith. He is our new finance director for Rutherford County, so he'll be sitting in from this point forward as ex officio member. So we welcome you, Michael. Next, we need approval of the minutes from our last meeting. Did anybody read them? Thank you, Mary. I knew Mary would read them for sure. We have a motion. Is there a second? Second from Mr. Spence. Any additions or deletions? Seeing none. All those in favor signify by saying aye. Aye. All opposed? Motion carries. Thank you. Next, we'll move into item number 3. Members on the agenda are financials. Mr. Elam, you're recognized.
Thank you, Chairman Ketron. For the 264 fund, you'll see for the calendar year, July 2022, revenue $1,953,212. Expenditures, $5,915,940. You have revenue less expenditures, a negative $3,962,729. The total for the fiscal year, you have revenue $51,905,092. Expenditures, you have $46,064,554. Revenue less expenditures, you have a positive $5,840,538. On the that was calendar year. On the fiscal year part for the month of July, you have $1,953,212, and the expenditures is $5,915,940, with revenue less expenditures $3,962,729. For the 266 fund, the month of July and the totals will be the same. Workers' comp, you have $7,860.05. OJI, you have $12,425.56, with a total of $20,285.61. That concludes my report, Mr. Chairman.
Any questions on either Fund 264 or 266? Mary?
Just real quick, on the 266, how many workman's comps do we still have open? Just ballpark. It's not many, is it? Is it 10?
7.
7.
7
okay.
active. Mm-hmm.
Okay. And I try to make a point for everybody, especially since these large numbers are on the television, just to remind, go back to the 264, the expenditures being $5.9 million, and we only took in 1.9. We have to realize that we did not and are not collecting, I think it's July and August
Yes.
premiums from the school board. So just for folks seeing it on the television, why is it so out of whack is because the teachers pay their claim, or their premiums are 10 months, and so I like to point that out.
Correct. It is on a 10-month basis deduction cycle, and you are correct. July and August, they're not collected.
Any other questions for Mr. Elam on either one of the reports? Ms. Allen.
Thank you. How's that going to work when the school board moves over to the state? Will they begin paying their premiums differently in January, or how's that going to work?
Well, you want to take
Mr. Smith.
The state will bill them for the total premium, and then it'll go back to finance for deductions, not through our office, but through the finance. Schools will work out the deductions, and then they'll send a file over to finance.
Mr. Smith?
We'll post the expenditures every month. They'll do a direct wire out of our accounts, out of the trustee's account. And then the expense will actually be posted as part of payroll. And then we'll take the payable off with a journal entry every month.
Okay, the reason that I was asking is I'm just trying to anticipate what this fund is going to look like when we stop collecting those premiums. Because we'll be paying those claims out through the end of December, but we won't be receiving any additional premiums, I'm assuming, after the December premiums we've received. They'll begin paying those towards the state plan. Is that correct? So I was just following up on...
That's correct. December will be, as we have it worked out now, and we're still meeting regularly, even as late as yesterday, but December will be the last premiums going into 264, and then January will be the wire directly to the state. But also the expenses then will shift, to the state as well. They'll be as part of that direct draft out. So the expenses won't be in 264 anymore.
Right, from January forward.
Correct.
But just in the balance of the rest of the year, we're going to be carrying that obligation.
Yes, County General.
Okay, thank you.
Mary?
Okay, along that line of thinking, is there going to be a run-out time if we're receiving claims through December 31st, but we receive that claim in January or February for a BOE employee? Are we anticipating the run-out and not really enough to cover, because, premium is a premium, but do we foresee that we're going to have a run-out period, and do we have a set date of, if we don't get it before now, we're not going to pay? It's as if we switched from long ago when we went from Blue Cross to Cigna. There was a so many months run out time because of trying to get the claims in, because a doctor's not going to file on December the 31st, because if you went to the ER or whatever, you're going to anticipate receiving that, but the claim is for a date of service in December. So how are you going to be handling that run out cost?
Mike can go deeper into it, but there is a fund. The 264 fund does have a balance, and it should take care of those run out. There's a calculation that Lisa does or has done, usually it's done in the month of July, to make sure that we have that amount of money in that fund for that run out, and that's been for the entire fund.
We do an incurred but not reported calculation. It's an actuarial determined amount, but essentially incurred but not reported. We do that every July for the fiscal year end to determine what our reserve should be. So that would be the same here.
Okay, other questions on either one of the funds? Seeing none, Ms. Thompson, if you would. I had a motion. Need a motion to accept both reports. Motion to accept both reports. Is there a second? Second, Ms. Brown. Thank you. Please call the roll.
Rhonda Allen.
Yes.
Dr. Andrea Anthony. Yes. Amber Brown. Yes. Shay Crowell. Yes. Brian Gaither. Yes. Mary Hickerson. Yes. Lois Miller. Yes. Jeff Phillips. Yes. Brian Runyon. Yes. Shantae Sherrill. Yes. Steve Spence. Yes. Eric Tutobeni.
Motion passes. And next we have item number 4, work comp and OJI Statistics. Ms. Thompson?
Yes, we're reporting on July 2022. The total for reportable for that month was 11. The accidents year-to-date is 96. Of that total 96, there are 72 recordable injuries year-to-date, with 39 claims restricted days, 11 lost day claims, and 22 other recordables. On the next page, you'll see a 3-year comparison with this year's total claims year-to-date of 96, in 2021, 93, and in 2020, 82. On the next page is the incurred dollars for the last 3 years. For 2022 year-to-date, we're at $340,000. For 2021, we were at $378,000. And 2020, we were at $340,000. And on the last page, for the month of July, there was 7 incidences at the Board of Education and 4 at County General. And of those 4, there was 3 at the Sheriff's Department and 1 at the Health Department. And that concludes my report.
Thank you. Any questions on the work comp OJI report? Is there a motion? Have a motion for approval. Lois Miller, second from Commissioner Phillips. Any further questions, additions, or deletions? Ms. Thompson, please call the roll.
Rhonda Allen.
Yes.
Dr. Andrea Anthony. Amber Brown. Shay Crowell. Brian Gaither. Mary Hickerson. Lois Miller. Jeff Phillips.
Yes.
Brian Runyon. Shantae Sherrill. Steve Spence. Eric Tutobeni.
Motion carries. Thank you. Next, we have our wellness update. Liz Levitt, Wellness Coordinator. Ms. Levitt? You're recognized.
Okay, so right now we are at a total population for everyone that's received their 3 incentive Motivate Me points. We are at 2,755. For our current and upcoming activities, we are currently out visiting all departments, doing our campaign called Wellness on Wheels, where we educate and consult all employees about any insurance questions, and we're happy to be back out doing that. We also are currently campaigning our biometrics with the MedPoint Clinic and promoting that, and that's already seemed to be filling up great. And lastly, we have a new communications outreach that we've created for a better way for people to receive all the updates through a podcast on our Rutherford County website, and that information went out today as well. And that concludes my report for this month.
Any questions for Ms. Levitt? Mary?
Okay, I've got two. The first one is definitely yours, hon. The point counts. Are y'all going to send out any more information, emails or something that we can post around the office and stuff, that I can remind the guys, since we are coming down to the wire of September the 30th, and I know it can get confusing because I'm sure you send it out to everybody, and these points will no longer be affecting our BOE employees because they're moving to the state. But do you have any plans, or can you please shoot us another email? It can be just plain and simple. Usually if it's something as simple as a one sheet that I can print off and post around for my guys to see, if you don't mind.
Yes, for sure. So what we've been doing is, well, the Wellness on Wheels, that's been, and I know with your department, I think we have to specialize at a certain time because everyone's everywhere, but we are reaching out to all the departments. We are currently have 8 already set. We're still setting more to talk to these people, but for a department like yours, what we were doing is trying to get in touch with y'all to see if, well, one, sending out a direct email like, hey, this is what you do. And so please feel free. I will write this down in my notes now to send you one directly if anyone else has that for their department that we haven't got to yet. I am more than happy to send that out so you know when we're coming, and that's something we'll do, or if you want to go ahead and contact our office, we'll go through all that with them as well, outside of just the email that explains the points, the time frame, and all that. So we have all that information. I'll send it to you directly. If anyone else needs that prior to us coming out, I'll be happy to send that.
Okay, I appreciate it. Those little
Yes.
things we post up, and it's like a reminder. And like this morning, we got a question from one of the guys, and we were like, yeah, actually you got till September the 30th. And he goes, oh, I got another month. He thought he had 3 or 4 days, but so he's got a month, so he's good in his mind. So, but yeah, it just is a good thing. And then my second question is, you said you in your Wellness on Wheels and things, you're talking about our benefits and our stuff. And this may not be you, and Ed, you may tell me to bring this up in a little bit. What are our communications, and what are and when are open enrollment?
Open enrollment's going to be 2 weeks. Off the top of my head, I believe it's the 14th through the 28th of October. Since we have less employees, we have, last year we had we changed our benefits administrator. We had an additional plan, and we had additional network, so we extended it for 30 days. And now, since it's not those changes, and so it's just going over the same thing again, we've reduced it, and with 1,200 employees, we reduced it down to 2 weeks.
Okay, that's good. Do we anticipate any kind of mail-outs or anything, mainly to get in the back of my mind of saying, hey, this is going to be hitting the mailbox, or when it gets there, I'm not surprised? Are we to the point that we're going to be able to have a open enrollment booklet or a couple of page stapled together kind of thing? Because I know we've come down to the wire on making some decisions that might not get published just yet.
Yes, so I'm in the process of working with One Digital on finishing up our guides and what leaflets we're going to put in there. And then MetLife is also sending out a separate thing about our accident and critical illness. They'll go to the printer the end of this month, the 1st of September, anticipating to go out a little bit later in September, so everybody has them in plenty of time before annual enrollment in October.
Okay, and it's going to be returned address Rutherford County, so that because I'm world's worst too. If I think it's some off life insurance, something, I'm zipping it up, throwing it away. So it will be a Rutherford County. Okay, thank you.
And just for FYI, because it is getting down to the wire for those incentive points, and a lot of people just didn't look at that when they got hired on, they don't know what to do, please let them know that we can direct them to the best way to get those done quicker, if that makes sense, because there's a long route and there's a shorter route that you can take, and we can help them, guide them. So please tell them to call us so we can let them know the best way they can get those before that deadline. All right. Thank y'all.
Thank you for the update, Ms. Lovett.
Mr. Chairman, I have a follow-up for Ed on open enrollment. Did we ever have a follow-up conversation with Cigna? At one point, we had talked about having the actuaries take a look at possibly allowing spouses to come back on and seeing how that was going to impact. That way you would be collecting a family premium. And could that versus the claims, is that something that we want to look at doing going forward? So are you thinking that would be a year from now? Or I just know we were looking at a way to try to replace some of the revenue that we're losing from BOE so that we're funding more into that program. I was just curious if we ever followed up on that.
Yes, at the moment, the bids are out for the broker of record. And so some things have kind of been put on hold to see in the proposals what the broker of records were going to bring to us, what ideas that they had, what other opportunities that different brokers provide for us to see where we can have additional savings. And I'll give you an example of today what you're going to have in front of you. You have the healthcare Bluebook, which is being brought by One Digital. It's just one of those things that they've brought to us since they've been the brokers since June, I think it is. So, and today, when they finish their presentation, it's just a program, and we're trying to see whatever we can find the savings that we can, and we will reevaluate once the new brokers put into place many different things, again, addressing spouses like we have in the past, seeing what that cost would be, and a lot of it depends on whatever, like this healthcare Bluebook, what we put into place. If it has the savings that, we're anticipating, and we decide to go that route, or, what else is out there for us, then it'll come as a bundle probably next, hopefully, February or March.
Any other comments? Seeing none, we'll move to item number 6. Ms. Amber O'Neill is going to make the presentation today on our MedPoint Report. Hi, Ms. O'Neill. Yeah, thank you. From the girl from Alaska.
All right, good afternoon, everybody. If you'll go to page 3 of the report, we'll talk about the visit summary. So we saw 669 visits in July. Of that, 532 members were seen that were unique. New Salem saw 348, Stewart's Creek 166, and Walter Hill 155 of that 669 visit total. On page 4 for our visit summary by member type, we saw 108 children, 478 employees, and 83 spouses. Page 5 for your visit appointment type, we had 109 members that had more than one visit in the month of July. 3 members had 4 visits, and 106 members had 2 to 3 visits. We had 129 annual visits, 35 behavioral health visits with our new licensed clinical social worker, Tommy, Shahan, so glad to have that service for the members. 20 dietitian visits, 343 established patient visits, which, as we've said before, is everything from a follow-up to sick care. 21 new patients, 84 nurse visits. Nurse visits are usually for lab, injections, things like that. 5 telehealth phone visits, and 32 virtual visits that included the full visual and audio components. Most of the patients with the multiple visits this month, as I looked into it, were seen for a combination of services that included well care, sick care, dietitian visits, and behavioral health. It was nice to see a really good balance in those multiple visits this month and people taking advantage of multiple different services that we have available to them, especially with the new behavioral health, and then also seeing an increase with some of the dietitian response. So that was good. On page 6, on the visit summary by day, July had 25 available scheduling days. There were 5 Fridays in the month of July. All the clinics were closed on July 4th for Independence Day, and Monday was the busiest day for the month of July. On page 7, for our in-person versus virtual visits, we had 37 virtual appointments in the month of July. Walter Hill continues to be the highest average of virtual utilization, with just over 12% of their visits being seen virtually, compared to only about 3% for New Salem and just under 5% for Stewart's Creek. Just over 70% of the virtual visits were done simply at the patient's request for convenience. And just under 30% of the virtual care visits done this month, in the month of July, were done for sick care. I was kind of sad to see, however, that of those done for sick care, over 90% of them were COVID positive. So we did see a little bit of that increase in July. On page 8, for our in-person versus virtual appointments for the trending since we opened. So we've had a total of 17,469 visits since we opened our doors in September of 2020. And of those, 2,700, or about 15.5% overall, have been completed virtually. On page 9, on our referrals by specialty, so we did a total of 95 referrals in the month of July, 52 at New Salem, 27 at Stewart's Creek, and 16 at Walter Hill. 19 of those were to gastroenterology. 19 were to our dietitian. So the good thing is when you see the dietitian and the behavioral health, which the behavioral health came in as the 3rd top referral source, those are referred in-house. So those are not referrals to outside organizations at all. That's simply to our dietitian that's part of our county plan, and the behavioral health that's part of our county plan. 8 went to cardiology, 7 dermatology, 6 each to otolaryngology and general surgery, 5 to endocrinology, 4 to podiatry, and 4 to physical therapy. On page 11, for our financials, in July, we had 532 unique members seen, $162,971.17 in our total operating cost. The employee count was 6,288 for a PEPM of $24. On page 13, for our diagnosis codes, the encounter for general medical exam, which is that annual physical, and anxiety disorder were the top diagnoses for the month of July. That annual physical, of course, especially with it being close to the end of the year with needing those points, was at 35.31%, so we like to see that. And then the anxiety disorder was 4.45%. Now, part of the reason you're going to see a higher listing of kind of those behavioral health diagnosis codes is because we do have the LCSW seeing people, and of course he's going to be coding his diagnosis codes for his patients. So we are going to continue probably to see that hit the top 10. It doesn't mean we've had an increase in those disorders. It means that we're seeing them more, so that's a good thing. And then, of course, rounding off the list, there was essential hypertension, sinusitis, pharyngitis for all those sick visits, screening for diabetes mellitus for those biometric screenings, and encounter for screening of malignant neoplasm of colon, which I love seeing in that top 10. That means that people are taking advantage of those Cologuard services that we've been trying to push out. And then we've just got some smaller ones kind of rounding off that top 10 there. On page 14 for our visit demographic summary. In July, we saw mostly women at 71.02%. The age range for female of 40 to 49 and the male age range of 50 to 59 were the highest populations seen in those demographics. However, we do still continue to see a good mixture of ages. If you'll see from the list, we saw 56 kids in the age of 10 to 19, and we even saw 2 members in the age of 80 to 89. So we really have a good balance throughout, but there are, of course, a couple of demographics that are just a little bit higher than that. And on page 15 for our BMI summary, in July, the female and male highest percent of BMI was in the overweight category of 25.0 to 29.9. And again, that explains why that dietitian was in those top referrals there for us this month. And then I just wanted to do a reminder, as Liz had mentioned, we are starting our biometric screening events. The first event starts this Saturday, the 27th. It will be going from 7 in the morning until 12. We do only do a half day because it is a fasting screening, so we don't like people having to fast past noon. We don't find that very successful. So we have that going on. We actually have about 100 people already signed up for this first Saturday, so that's great. And then we will continue those every Saturday in September, except for Labor Day weekend. We find that's not a very successful weekend as people are traveling. So that's why we started it at the end of August instead, to kind of make up for that Saturday we won't be doing over Labor Day. I do encourage people to sign up ahead of time. It does allow us to prep everything for them and give them a faster experience and get through, and just it'll be better for them. We pre-do all their paperwork, we get their orders in, and they'll have a lot less time in the practice if they sign up ahead of time, and they also will be seen before those who walk in, because they have a guaranteed kind of scheduling time. And I would encourage them to schedule in the September visits, because that Saturday coming up here in August is already getting pretty booked. We also are going out with Cigna and partnering with them for the Wellness on Wheels whenever possible, to also give out information about the clinics and to help people get signed up for things. I've even picked up my cell phone and called and got people scheduled while they came in to talk to us at the Wellness on Wheels to get their points. So we're happy to partner with that and help to get people their points. And that concludes my report.
Thank you so much. Any questions for Ms. O'Neill? Mary?
And I don't mean to put you on the spot, it's just this come up this week and I knew I was going to see you instead of just send an email or whatever. But we've had a couple of our employees go to the Salem Clinic, and when they get sent downstairs for x-rays, they don't realize that that is going to be a cost service instead of as part of their visit upstairs for whatever they're being seen for. So we've had a couple, and one just within this last week, come in and go, why do I have this bill? Because he said, I went to the clinic and they sent me downstairs for x-ray. So just mainly a mental note, can you kind of get the ladies and gentlemen or whoever's over at the Salem Clinic to make sure the guys and gals know that when they go downstairs for x-ray, that's it's a different charge, or, because if I'm at Stewart's Creek or anywhere, when I leave, I know that's done with that visit. Yes, you're sending me somewhere, but the unfortunate thing is at Salem, you're just sending them downstairs. So.
And generally we do have that conversation with them, so I don't know how it is that those people, maybe there was a miscommunication or something like that, because we do tell them, we're sending you to Premier Radiology. They are a separate entity. It's just like if we have to refer them to the hospital for anything that we send them to, we try to tell them that as well. Hey, you're going to the hospital for a special test or something like that. So I don't know where the miscommunication was. I'd be happy to talk to those patients if you'd like me to. But we do very clearly, and we also tell them, hey, they're not even Ascension. Like, they're Premier. They're outside of our organization, but they partner with us to provide those radiology services, and they happen to be on site. So we do really try to communicate that, so I don't know how that was missed, and I do apologize if it was missed, but that is a regular conversation we have.
Well, I mean, I just know that, I realize Premier is separate, I just know that, but some people's mindset is it's still in the same building. you
Yeah,
know?
no, I understand,
mean,
yeah.
I hate to be that way, and we satisfied his answer, and it was going to be, not that any mere money is mere money, but it wasn't an astronomical charge that he was going to have to pay. So all of it is sorted. I'm just kind of making a mental note, if you can just try to make sure that if they're not, or say, hey, you might want to say it a different way, that, look, yes, you're in the same building, but they're totally separate.
We'll revisit that with the staff just to make sure we update all that training, just to make sure everybody's still following that procedure, because that is, like I said, a regular conversation that we have.
Okay, thank you.
You're welcome.
Any other questions? Thank you, Ms. O'Neill. Thank you.
Thank you.
Next, members, we have our healthcare blue book. I'll turn it over to Mr. Elam.
Yes, sir, Mayor Ketron. The Rusty Ferris with One Digital has brought this Healthcare Blue Book to our attention and for us to take a look at it. Frank Hess with Healthcare Blue Book is here just for the presentation as, a product that they have to offer. So I wanted to bring it before the committee. So Rusty, are you or Frank coming up, or both? All right.
Hello, gentlemen.
Everybody, thank you for your time today. Appreciate the introduction, Ed. Think of the last two topics we've talked about, on-site clinics, wellness visits. What we're all trying to do is try to utilize healthcare at the highest quality but at the lowest cost. And right now it's difficult to do that. If you think about the claims that hit your bank account every single month, it's a unit cost times a frequency. How many times did I get that procedure done? Add the two together, and you aggregate it over the multiple procedures you have, that's what hits your bank account monthly for medical claims. What Healthcare Bluebook is going to show you guys today, guys and gals, is there's a better way to educate your members before healthcare occurs so that they can get the highest quality at the lowest cost. And the most important part of that is the incentive to reward that employee when it saves the county money. So again, we're talking about with Cigna, wonderful organization, with the solutions you guys did last year, adding the Local Plus network and also putting in a HSA, great solutions. We're building onto a multi-year strategy. What's the next thing with it? So within Cigna's network of providers, the very broad network, half of those providers graduate the top half of their class and half of them the bottom half, but they're all providers. What Healthcare Bluebook is going to do is to show us which ones are the top third quality and also match that up with what's the lowest third cost to then have an excellent outcome. So with that, I'm going to present to you Frank Hess. He's the representative from Healthcare Bluebook, and he'll walk you through about a 20-minute presentation. At the end of the presentation, there'll be a Q&A session. So if you have a question, if you can't hold it, that's great, but if it's something that you need to ask right then, feel free to do so. Frank, it's yours. Thank you very much.
Thank you, Rusty, for the introduction, and thank you, members of the committee, for having me here and allowing us to share our story. So we are Healthcare Bluebook. We are a cost containment solution for self-insured employers, but really that's just a byproduct of what we do. What we really, our mission statement is to protect patients by exposing the truth and empowering choice. So really what gets us out of bed every day, what our North Star is to empower families to get the highest quality care for the lowest cost. And we do that through an online shopping platform that I'm going to present to you today. There are a couple of exhibits that you have in front of you, hopefully, that will show you some screenshots of our solution as well as a copy of this presentation. So we are a local company. We were founded by a physician in Nashville, Tennessee about 15 years ago. His son needed an ankle surgery, and he had some physician friends that could do the surgery, and in the old days he had to pull out the phone and call, how much is this going to cost? And so what he found was that this procedure was going to cost anywhere from $1,500 to about $15,000. And it was the same physician friend that he had. The only thing that changed was just who owned the four walls, the facility. So that's how the idea of Healthcare Bluebook was born. And Truett Cathy said about 60 years ago, Truett Cathy with Chick-fil-A said, we didn't invent the chicken, we just invented the chicken sandwich. And I like to say at Healthcare Bluebook, we did not invent healthcare, certainly. We did not invent transparency, but we do state the claim that we invented healthcare transparency about 15 years ago. So like any other small startup company, we had our trials and tribulations in terms of growth. Over the last 5 to 10 years, we've really flourished as a company. As you can see today, we have over 10,000 different employer clients of all shape and size. We have over 7 million lives on our platform today. And you can see some of our logos, just some of the groups that we work with. The top left there is the state of Florida. That is our largest client that we have to date, with about 350,000 members. And then on the top right there is Miami-Dade County Public Schools, which is the largest school district in the United States with about 30,000 members. And of course, you'll notice a lot of other private sector groups there, ranging from all different types of industry. And really, this is somewhat of a self-serving slide, but really the broader point of this slide is just to convey that regardless of shape or size, whether it's a Fortune 500 company, if it's a small business, if it's public sector, private sector, blue collar, white collar, it really doesn't matter. At the end of the day, all organizations that have a commercial healthcare plan are impacted by the same problem of both cost and quality variance, which I'm going to be talking about here in just a few slides. One thing I did want to point out is that we are unbiased. We are not here to serve or work for the insurance companies or the hospital plans. Again, at core of our mission is to protect patients by exposing the truth and empowering choice. So we are that unbiased source. We're carrier agnostic. We work with all of the BUCAs, all of the large insurance companies, as well as about 50 different TPA partners. And so again, our job is just to show employees and members where is going to be the best outcome at the best price. And if you refer to one of your exhibits, you can see some examples of a colonoscopy here in Murfreesboro, Rutherford County, as well as total knee replacement. You can also look at doctor search, and we'll get a little bit more into that. I just wanted to let you know that that is there. We also have a client retention rate of about 93% that's a really important thing for us. So the first thing I want to do is just give you a sense of what some of the results that our clients see. And when we look at our book of business, most of our clients generally see about a 20% utilization, which may sound low to you, but keep in mind that about 70% of your average workforce is pretty healthy and doesn't have an active need to search for a healthcare procedure or service in any given month. So really 20% is really out of about 25 or 30%, if that makes sense, in terms of the total population that would need to look for a healthcare procedure or service in a given month. And that yields about a 4-to-1 return on investment, which in terms of a per employee per month savings is about $12 per employee per month. And then we have an incentive rewards mechanism, which really is what creates the rapid employee adoption that Rusty was talking about. That's the carrot that we dangle in front of members to help get them to change behavior, because at the end of the day, shopping for healthcare is kind of a foreign concept for a lot of people, and so the rewards we found to be extremely successful in terms of incenting that behavior change with the reward. It rewards that positive shopping behavior. So in our program, we see about a 10-to-1 return on every dollar. So Rutherford County would be funding the rewards for the members of the plans, and what we can show is about a 10-to-1 return on on each one of those dollars that we can verify through claims experience on the back end. So it's a really concrete ROI story that our clients like. So just a couple of notes about quality, and then we're going to turn the coin over and talk a little bit about cost. On the quality side, it's just really important, and by the way, I'm going to show, after this slide, I'm going to show you where does the data come from, because that's what a lot of people want to know, is how do you know what good quality is versus bad quality? So I will get there in just a slide or two. But first, I just wanted to showcase an academic medical center. This is Stanford Medical Center, actually, that we're looking at. And so this isn't to pick on Stanford or any hospital. The bottom line is hospitals all do some procedures very well, and they do others not so well. And it's just like human beings. There are no perfect human beings. There's no perfect hospital. Hospitals, at the end of the day, are responsible for providing thousands of procedures and services, so it's just physically impossible to be top-notch at every single one. And so we use this example to show that at Stanford, neurosurgery, they have some of the world's best neurosurgeons. They're in the 99th percentile of all hospitals in the United States for neurosurgery. We look at other procedures like gastrectomy surgery. We find that they're middle of the road, about 56th percentile. And then for bariatric surgery, they're in the bottom 10th percentile. So if you were to throw a dart at any hospital, any of the 5,000 hospitals across the country, about 90% of the time you would find better results. And so again, that's how we do things at Healthcare Bluebook, is just to highlight highlight the truth. It's not favoritism, it's just exposing what hospitals, what their strengths are, what their weaknesses are. So just to bring it more local here, Ascension St. Thomas Rutherford, when we look at the data, they are extremely good for total knee replacement. They're in the 99th percentile. In fact, out of over 3,500 hospitals in America that do total knee replacement, Ascension St. Thomas Rutherford is number 20 out of over 3,500. So that is really, really impressive. If you're a patient and need a total knee replacement, that would be the place to go. We look at other procedures like gastric bypass surgery. They're more middle of the road, 42nd percentile. And then we look at procedures like brain tumor removal, and we find that they're in the bottom 9th percentile. So our strategy is not to go all in with a particular hospital or healthcare provider, because when you do that, you take the good with the bad. And so our strategy is simply to get patients to the safest place with the best outcomes at the best price, regardless of what the name on the side of the building is. So the other important thing to consider when we think about quality is just because a patient finds a great hospital, like the 99th percentile for neurosurgery here at Stanford, that doesn't necessarily mean that you'll end up with a great doctor. Doctors are human beings. There are some that are better than others. And so we look at the outcomes, attached to the physician as well. And so our concept is very simple. We want patients to marry a green doctor quality with a green facility quality to optimize the success rate of the patient, if that makes sense. So that's just another factor that goes into the decision-making process. And so here's the fun data slide in terms if you're wondering, where does all this data come from? So Healthcare Bluebook, as I mentioned, has been around for about 15 years. For a long time, we've been known as the leader in the industry in terms of cost data. About a year and a half ago, we acquired a company called Quantros, which if you've heard of Quantros, they've been known as the gold standard for quality data. So that was a really important move because that brings together the largest data set of cost and quality in the United States. So now we understand what the true intersection of cost and quality is, and that really is a powerful combination. So in terms of where the data comes from, and we're really going to spend our time on the medical side for right now for this discussion. The top part is the cost, and so we're using aggregated commercial claims. So we're using Cigna, all the national carriers. As I mentioned, we have about 50 different TPA partners, and we're looking specifically at the allowable in-network charges. The reason we do that is we want to look at the end of the day what was paid for a procedure in the commercial insurance market, because we believe that's the best way to consumerize or to shop for healthcare in the commercial insurance market, is to look at what was actually historically paid. All the discounts and the moving shell game of everything, we want to know at the end of the day, brass tacks, what was paid. The other significant thing about that is when we look at the allowable amount, that represents the total amount paid for a procedure by the employee and the employer collectively. So if you refer to total knee replacement, for example, in one of those exhibits and you see our fair price and we put a price spectrum, that price is all in terms of what was actually paid by the employer and the employee. And that includes anesthesia, the doctor fee or the professional fee, as well as the facility fee. And then we validate that against billions of claims. And then we refresh that monthly to make sure it's current and accurate. And then we simplify it for member consumption. And we use a stoplight, which a lot of our clients like because it really just makes it simple, red, green, yellow. Most people can easily understand that. On the quality side, we use CMS, Center of Medicare Services, for our data set. And there are really two primary reasons for that. Number one, we like the volume. It's the largest data set in the American healthcare system, so volume is really important when you're looking at quality. Number two, we like the fact that it's objective. It's entirely outcomes-based. So we're looking at things like mortality rates and readmission data and a whole host of other different patient safety events. Then we risk adjust that and volume adjust it. So we risk adjust it to reward hospitals that take on sicker patients based on where they're located geographically, or conversely to not penalize those hospitals that based on where they're located geographically take on sicker patients. And then we volume adjust that. So as an example, in Murfreesboro, if one provider does 10 total knee replacements a year, and another provider down the road does 100 total knee replacements per year, even if their outcomes come in at exactly the same level, the provider that's done 10 times as many has a higher statistical likelihood for the patient to have a safer outcome, if that makes sense. So that's just an example of volume adjustment. And again, we'll take questions. I'm sure there'll be some questions we'll take at the end. So just kind of flipping the coin over from quality to cost and talk about that a little bit. When we look at the data, what we find is that prices vary drastically even in network. In fact, usually between 300 and 1,000% in most cases. This could be, in this example, whether it's a major procedure like a total hip replacement, or if it's not a surgery-based type of procedure like a colonoscopy or a shoulder MRI or an infusion, the prices in network vary pretty drastically. And a lot of members, most members in fact, don't know that. And so just wanted to make it more local here and share with you a price variance report for Nashville and Rutherford County. Now, Nashville and Rutherford County are considered part of the same shopping market, if you will. So if you needed a total joint replacement, for example, you would want to look at hospitals in the area. And so this is a basket of 10 very common high-volume procedures. Note that none of these are all outpatient, so please note that none of these have a quality variable. A lot of these are imaging, things like MRIs and CTs and sleep studies, things of that nature. So these are cost-only types of decisions, and you can see the low in-network price in green, followed by the high in-network price on the right, and then the total variance on the far, far right. And so what we find is that the variance in this market is about 554%, which is pretty consistent with what we see on a national scale. As I mentioned earlier, about 300 to 1,000% is what we see in most markets. So we like to use something that everybody can relate to, like buying a gallon of gasoline, and that would be the equivalent of driving around Rutherford County with gas ranging between $2.50 and almost $14 a gallon, which just seems absurd at face value. The difference is in the gasoline industry, they're required by law to post the price on the side of the building, whereas in healthcare, it's not like that. So most employees or members operate in total price blindness, meaning that they have no idea what things cost. And a lot of times they think in terms of in-network and out-of-network, and that's a good thing. But a lot of times members will say, okay, I checked this provider, they're in network, I've done my job. However, the prices can be 300 to 1,000% variance. So that's key to one of the value propositions that we bring, is to really educate members so that they know just verifying in network is not the only step. There's also some additional savings to be had there. So in terms of what's driving this cost variance, why is there a 554% variance in Nashville, Rutherford County? When we look at the data, the answer to that question is it's the facility. As I mentioned earlier, it's all about who owns the four walls that you have any medical procedure in. And to illustrate that, we have a graph of total knee replacement procedures in Fort Collins, Colorado. Now, we do business on a national scope, and regardless of procedure or market, it really resembles this half shape of a butterfly. And what we often see is that right here is the orange represents the facility cost for that procedure. You can see the dark blue represents the anesthesia cost for that procedure. And then the light blue is the professional fee, or what it called the doctor's fee. And so we do find that there is some variation in terms of the doctor's fee and the anesthesia, but really what's driving this huge variance from about $18,000 to all the way over $100,000 is the facility. So it's really a site of care issue, is really one of our key focus in terms of delivering savings. So in most industries, quality is perceived by cost, right? The more you pay for something, the better it is. So the $60,000 car must be better than the $20,000 car. In healthcare, that couldn't be the furthest from the truth. There's no correlation between cost and quality. And to illustrate that, this same graph, each one of those, again, is a unique case for total knee replacement. We have the green, yellow, red for quality. And so if you see at the top of the screen, some of the most expensive cases there were actually very poor quality. And as you get closer down to the fair price, around that $20,000 or $30,000 mark, you see a lot of green and some good outcomes. So the net is that there's really no correlation. In fact, there's some at our organization that would submit that if there's any correlation, it would be an inverse relationship between cost and quality. Okay, so now we've talked a little bit about the problem. What is the solution? When we look at healthcare, we think of economics, a supply and a demand side. And so there are a lot of solutions out there that you can impact the supply side. You can curate networks, you can do all sorts of things. What we do is we focus on the demand side of the equation and inform members of cost and quality. And we found that that's just a crucial element, and again, the rewards mechanism to really drive that. So looking at this slide, this is our strategy, and we have a variety of different clients that use various configurations of our solution. And on the left, our core SaaS solution, or software as a service solution, is really just the information only. So we have cost, doctor quality, and we have facility quality. You can see the utilization and the return on investment. And I do, coming up, have some government entity slides and what their results have been like. So keep that in mind as I show you some of these, how there's a spectrum. There's a reason why. So when you have just the information only, the information is very powerful, but if you don't have that incentive behind it, what we found is that the utilization is much lower, and obviously the return on investment is correlated with that. When we introduce financial incentives and some of the high-touch engagement strategies, like a concierge layer that we've added on, what we found is that really increases the utilization. And then to the far right is a Centers of Excellence concierge type of model where we reward members for going to high-quality, low-cost procedures. And what we found is that really results in the highest utilization and ROI. So within that is called Bluebook Care Connect, and there is an in-network navigation piece to that. There's also a bundling or direct contracting capability that's there. We believe that the best value is often inside the existing network, so that's generally what we're trying to do. However, some large employers, are interested in potentially going out of network, so we have that capability. And then we have a pharmacy solution that we introduced January 1st of this year that makes us the first vendor to have medical and pharmacy on the same member platform. And we found that really increases the results as well. So we're going to talk a little bit about the return on investment that we have projected for Rutherford County based on some of the numbers that were provided. And before we do that, there's really two key pieces that drive those results. So I just want to take a moment to talk about engagement rewards and then Care Connect, which is the concierge layer, just so you understand what those numbers mean when we look at that slide. So engagement rewards is we have about 1,500 procedures in Healthcare Bluebook. Of those 1,500 procedures, about 400 of them fall into our engagement rewards program. We focus on high volume procedures that have high variance. They're very shoppable procedures. And we're continually adding new procedures. We add new procedures twice a year. We have rewards up to $1,500. So for a spinal fusion, a member could get a $1,500 reward. That sounds like a lot, but keep in mind, we see on average about a 10-to-1 ROI. So that would generate about a $15,000 savings for the county every time we do that. It might be $100 if it's an MRI. It really just depends on what the value of the procedure. The outcomes that we show is based on attribution, so there's no luck or happenstance. What we do is we get the claims data from Cigna. We're able to tell who goes to a high-value provider through claims data, and then we use the eligibility data to verify that member actually searched for that procedure in Healthcare Bluebook. So they have up to 12 months when they search for a procedure in Healthcare Bluebook, they have 12 months to receive care before they're to be eligible for the reward. So that's engagement rewards. To date, and this number, it might be a little bit outdated, but we have issued over 406,000 total rewards and over $24 million. So it's really been kind of what's driving a lot of the results that we see. The second piece that I talked about is called Bluebook Care Connect. Again, that's the high-touch concierge layer that we've added on. So we know that members can self-serve pretty easily, especially when it comes to things like MRIs and colonoscopies, and sleep studies, and things of that nature. The more complex a procedure it is, the more expensive it is, generally speaking, and we know that it can be more difficult to self-navigate. So that's what we're focused on, and at the end of the PDF that you should have, which is a copy of this presentation, you can see exactly what that procedure set is and what the rewards are and what the case rates are for that. But the bottom line is, we know that the clinically harder to move cases are higher dollars. So to give you an example, we could convert MRIs and CTs all day long to high-value providers. All it takes is one spinal fusion to offset a lot of that savings, because I think the range for spinal fusion is about $40,000 to over $120,000, $140,000 in this area. So you go to the wrong place for an expensive procedure like that, it's really, really costly to the plan. So the reason we have this is we want them to engage with us. We use the engagement reward to help drive them to the best provider. And we also know, just from the member perspective, we know it can be very frightening and intimidating to have a major procedure. They may have just received some news that's not very good, or going through something pretty tough in terms of a prognosis. And to balance work and family and to shop for a major surgery can be pretty pretty daunting, so we just want to hold our hand and just lead them through the entire journey. We facilitate medical records transfer. We do all the pre and post-op communication. And again, we just really hold our hand the entire way through. And then from the plan savings perspective, as I mentioned, we really just want to protect the savings there and make sure that they don't go to the wrong place for those high-cost procedures. And what we found is that that increases savings by about 50% additional just by having that mechanism in place. So now that I've explained engagement rewards and Care Connect, this is the ROI estimate that we have for Rutherford County. And so and I know this is kind of tricky to look at. If you look at the third line, which says Bluebook PEPM fees annual is $2.25 per employee per month. That's the baseline that would be paid is $33,000 a year. And then if you look, the top two lines above that are the engagement rewards program and Care Connect concierge that I mentioned. And we like to use a range from low to high, just to give you kind of a sense of what range we would expect to look at based on our book of business. And we would estimate from a rewards perspective that cost would be between about $11,000 and $23,000, with savings of $107,000 to $222,000 just for the engagement rewards piece. And then the Care Connect piece below, we would estimate between $5,000 and just under $15,000 for the case rate fees. We only charge a case rate fee when a case is successfully placed. And again, you'll see more information in your packet on that. And for those concierge cases, we would estimate savings to be between $23,000 and just shy of $70,000. So if you want to look at the grand total on the bottom, we would expect the total cost to be somewhere between $50,000 and $71,000, which would yield a savings of between $130,000 and $291,000, with an ROI range of between 2.6 and 4.09. These are generally pretty conservative. As I mentioned, most of our clients, we generally see about a 4-to-1 is what we generally see on average. So as I mentioned, just some government client ROI examples. And I put them in two different sides here because on the left is our standard rewards program. That's our older model that's been around for about 10 years. And about 3 years ago, we introduced engagement rewards, which we've seen translate from about a 10% utilization to about a 20% utilization. So when looking at some of these county governments, looking at Miami-Dade, for example, and Pinellas County is a part of Tampa, the Tampa market, and then Sumner County here, right in the Middle Tennessee area, they're using our older platform, and you can see some of the ROIs range from 1.9, 2.5, 3. Blount County, Tennessee is just launched earlier this year, so we don't have outcomes or results for them yet. On the far right is really what I want you to focus on because that's what we're proposing today, which has higher utilization. So Sarasota County, Florida, 2.9 to 1 in their first year. And just like anything else, this tends to grow over time. Larimer County, Colorado, 3.6 to 1 in year one. We have a Collier County Sheriff's Office in Florida, 4.5 to 1 in year one. And then the state of Florida, which again, 350,000 members, 5.7 to 1 in year 3. So that just shows years 2 and 3, it does get larger. And then the city of Cleveland, Tennessee is implementing right now and going live on 11/1. So, we would love to have the opportunity to have Rutherford County move forward with something like this. It's, something that's forward thinking, but it works and it's the right thing to do. And I appreciate your time, and I'll welcome any questions that you have.
Sonia?
I've got a couple of questions. So on slide 14, when we were talking about the savings of looking to see who had the better value for the procedure, we'll just say, knee replacement or whatever it was you said. Does this take into consideration, so I may have a general doctor that I've used before. Let's just say I've gone to TOA. And I may have had a procedure. So they always have a new patient setup. So you have to go 1 or 2 times. You have to go the first time, meet the doctor, they do a workup, then you have to have another appointment. You go back and you get your x-rays. So does this savings include, so let's say the next time I have to have a surgery, they send me to Knees on You or something, whatever the name of it is. But you have that new startup. Does this savings include that new patient setup that you're going to have? You may be going to a more cost-effective location, but the startup costs are still going to be there as a new patient.
I think there's a microphone. Yeah. Great question. I think I understand what you're saying. So in our tool, we have over 1,500 procedures. You could look up office visits for a specialist, or in primary care, for example, you could look at office visits. What we found is that the variance isn't very large when you just look at an office visit. So really it's the proceduralist and the actual procedure itself that has that large variance of 300 to 1,000%. So that's what the rewards are really based on. So to answer your question another way, we do show information about the office visit and some of the startup costs like you mentioned, but the rewards program itself is really geared around that actual procedure.
Okay. Then I have two more questions.
Okay.
So the next question is on page 15, where it talks about, page 15 there, I did want to point out, it says at the top of this grid that it's strictly confidential and do not duplicate, and I just wanted you to realize that this was a public meeting and that people were seeing this, so in the event you had not intended that, I want you to know. And then on page 16, where it says like the 2.9 to 1, are you saying 2.9% savings to 1, or what are you referencing? I'm not sure I'm under.
Sure. On the county population, we could say for every % increase in total budget, it's about $150,000, $170,000. So if we were to put this solution in the first year, we don't know if it's going to be exactly 2.6 or if it's going to be 4.09, but what we're saying is if we can achieve 1% of savings, that's that's a 1% lower increase in your overall cost. And that's where I'm looking at. $138,000 is the savings, $50,000 is the cost, so that's $80,000. On the right-hand side, we're looking at about 220. So just taking the middle between that two, we would say the first year this would generate, on top of the cost of the program, about $150,000. And when we say ROI, there's an actual physical guarantee on it. So explain a little bit how that works.
Yes, absolutely. So contractually, we will offer a 1.5 to 1 guarantee. It's just to know that you'll break even. We have never had a client not achieve a positive ROI in year one, and we're willing to put our money where our mouth is and offer a 1.5 to 1 guarantee. So that's the worst case scenario.
If there was a question, this is not something that we would replace Cigna with. This is helping us navigate within Cigna's network to, again, find those best quality providers or facilities at the lowest cost. Because, again, a network is broad, and any insurance company has to have enough providers and hospitals to have a very comprehensive network. But, again, there's the highest and there's the lowest, and that's what that exhibit shows. We're trying to educate, but if you just educate and that's it, and you don't put an employee reward on it, then you'll have some people engage, but that's where that 10 to 1 savings comes in. If you give someone $100, they're going to say, you know what, hey, doctor, I got my mobile app here. It says I can go to Premier Radiology instead of in the hospital, and I see it's an $800 variance. Is anything wrong with going to Premier Radiology? If the answer is no, as a member, if I go to Premier, I get $100 and the county saves $700. So again, it is, a lot of times benefits are about, let's change the deductible and shift more to the employee, or those kinds of things. This is actually making the benefits richer, and it's a lower cost to the county. So we call that the unicorn benefit, because not a lot of them out there. It's a better benefit at a lower cost, and this is 100% voluntary to employees. So we're not saying if you don't do this, you don't get your procedure. All we're saying is when you do choose, get on your mobile app or get on your laptop or call the 1-800 number. Is that 800 number? If you do that, if you're willing to do that, you're going to get rewarded up to $1,500, and it can save the county more than $15,000. In some situation, you saw like a spinal fusion, you could save the county $20,000, $30,000, $40,000, and that's how you can keep your future benefits and budgets sustainable instead of every year it's just another 8 to 12% increase. And what do we do to fight health care? This is a way to fight it, but it's better for employees.
Mary?
Okay, I got a couple of things, but I'm going to start at the back and go forward. Over on 13, which is going to tie into a question over on 3, the rewards that you keep talking about, where does that money come from? And how are you going to, if it's money which, if I understood everything right, it's money that's going to come out of the county's pocket. So if that's the case, then how are you going to get it to the employee? and I don't mean to say legally, like we don't do any, but like with all the tax stuff. And sorry, Michael, you'll learn. But I mean, how can we, so you've got money that is incentivized by health stuff, so how do we get that back to our employees? And so, in a nutshell, we're paying a premium, a premium to have this Bluebook so that our employees can shop, which sounds real good and everything, don't get me wrong. So we're gonna shop, we're gonna get the deal for us, but the county also in the background is going to have to put a fund to fund our employees for making these good choices. Now, with all of that being said, we're trying to figure out a way to make a plan for 1,200 to 1,500 of us that's going to be left after January. It just bothers me I get it, I see the savings, because then we're going to roll up to page 3 is these numbers that you've just talked about here. Are these our current numbers of the 20% utilization with BOE with us because you looked at the numbers now, or did you look at the numbers of what's going to be left as of January 1st?
Sure. We use the 1,230 members that is not included in the BOE. We would love to add that at some point, but this was just for the county. And then to go back to your question, we are not forcing rewards. If you look at the left of the screen, you could just offer cost and quality only. The premium shopping, as you mentioned, with no rewards, that's generally the results that we expect to see. And then just to corroborate that with some of the counties that we work with, and this is actually rewards, but just using not as a powerful engagement type of rewards, you can see the ROI is a lot lower. So it's not that we're forcing rewards, but that's just how we drive our savings. That's where we get the best results. And again, it's all about behavior change, and it's about people like getting cash in their mailbox. It's just, it's a nice thing. It rewards positive shopping behavior. And that's how we've been able to build cultures of consumerism around healthcare nationwide. And then the other part that you asked, I think, is how does that work? The county does pay for the rewards. We send the county a list of all the rewardable procedures. The county does pay for that, and then we send out the rewards at Healthcare Bluebook. There's no administrative fee. It's not a profit center for us. It behooves us for us to have happy clients, to see good engagement and savings levels. That's why we have the 93% retention rate that we talked about in the beginning. Historically, those have been paid out in the form of a check. Now, as you can see on slide 19, we have rewards debit cards and we have Bluebook saves cards. So there's different ways to structure it. You could tie it into an HSA card. You could make it a cash reward. There's different taxation options, and we're happy to sit down and figure out what the right solution for you all would be. It's very, very flexible.
One other thing to add on that, when someone hits their deductible or someone hits their out-of-pocket max, we kind of call those the anti-consumer, because it's 100% on the county to fund every dollar of claim over my out-of-pocket max. This is a way, even though with the out-of-pocket max, you're keeping employees engaged and shopping around for finding that best procedure at a lowest cost to, again, help the county on managing both the current and future costs with that. That's also part of it. Mary, the question you asked about, and this is the number one question the HR teams ask, who's going to cut these checks and how do they get to employees and manage it? That's part of that. The fee that's paid to Healthcare Bluebook is to cover all that administrative. You guys can tax up, you can gross down, and then submit as a W-9 for any procedures over $600, the W-9 will go to the county to be factored into the total compensation. And then the county, if it's over $600, that employee would be taxed on the amount over $600.
Okay, now okay, I got that. But now I need to know a little bit about your company, in that you were founded in Nashville about 15 years ago, if I'm making sure I picked up right. But you keep talking about down to the 4 walls of the red, green, and yellow. So how does, and it can be a simple answer because I know some things are proprietary, but Who are your investors that y'all are able to come up and do things like this? Do you have the doctors that might own the four walls at one of the x-ray or outpatient surgery facilities? Do y'all have that same thing in the makeup of Healthcare Bluebook Company or whatever your name is? So what makes y'all that? And then, this is probably an Ed question. We get this, and I know this. And y'all work with Cigna, I get that. But does Cigna offer something already not maybe offered right now for us, but does Cigna and our reps offer something similar to this for the county, maybe same cost or less, and have our history with us than having to go to Healthcare Bluebook?
We go with the first question to you all and then to Ed.
Sure, I'll take the Healthcare Bluebook question. So we are owned by a private equity firm called Primus Capital. We do not have any kickbacks. We're not affiliated with hospitals or providers or anything of that nature. That directly contradicts, what our mission statement is. So that's that piece. I'm trying to remember. What was the second question?
We'll let Ed answer the other one, if it's okay, Ed. The Cigna, then Paul, if he wants to add anything to it. Mary, on the question again, this is what employers are asking us again. What are ways we can control our healthcare costs, and without disrupting our employees or making benefits cheaper to employees? I mean, diminishing the value of it. And this is one of those things out there. If Healthcare Bluebook is steering people to higher cost facilities or lesser qualities, that would go against just the Medicare, Medicaid data and the Quantros. External validation system instead of internal Blue Cross, Aetna, UHC, Cigna, looking at their data and trying to work within their network. We're saying all networks are open, all providers, all facilities are open, using external validated data to make sure there's no conflict of interest on it. Ed, did you want to address anything on the Cigna part?
No, we have had some conversations with Cigna. Paul's in the audience, and he wasn't on the presentation, but if he'd like to come up later and talk about it, we have done a little bit of comparison between Cigna and this one with Healthcare Bluebook, and we're also researching what other ones may be out there. My intent in this meeting was the agenda wasn't so heavy this month, and to try to bring it before you, knowing that September and October's agenda is going to be pretty heavy, and not add this in September and October. We may be a little bit ahead of the game here, but I wanted to present it to the committee so they would get an idea, not just Healthcare Bluebook, but what we are looking at. So when we bring something to you, it's not the first time you've seen it, and we're having 3 or 4 presentations. Part of it is looking at is this something we have to bid out? And I know there's other municipalities that have used it. So again, today's meeting is just more of an informational meeting, and also to get these questions that you're asking are very helpful to us as a department to decide how do we move forward and what we need to look for also.
Mary,
I'm sorry to. We did view the Cigna presentation. Cigna has a very good solution out there, but the limited procedure, the procedures are limited in terms of more bones and joints with it, whereas this is looking at 440 procedures and steering across the very much more broader situation. Cigna's adding additional things in to that solution, but it's not as broad. And from our standpoint, the rewarding mechanism, Healthcare Bluebook has a much better way to say debit card to you or check to you. Here's the dollar amounts to encourage that behavior with it. And Cigna's a great solution. 10 years from now, Cigna's not the right solution. Employees are still comfortable with Healthcare Bluebook as an external solution, mobile, computer, phone number, instead of embedding everything with the same carrier on every single thing. Did I help address?
Yes,
okay.
Thank you.
You're welcome.
The main thing that I always try to remember and point out in any of these meetings when we're making a decision or getting information, and I appreciate this, is we got to remember who our audience is. All of this and the little 4 examples later on pretty much tells me I need a smartphone or access to a computer. Well, my crew, which is only 70 people of the 1,230 we're going to have, they don't have one of these, or if they have one of these, we're helping them in the office, or their daughter or their son is helping them, because we do have a little bit older population. So we have to remember whatever we're wanting to implement, although it's going to be voluntary, we got to know our audience, and how can we make something like this that looks really, really good, how can we make it work for everybody? Because believe it or not, I still have people with flip phones, my mother being one of them, who will still be on our plan, and then I've got some that use the computer in the office because they don't have one at home.
That's, I'll let Frank talk to specifics with it. The way benefits in general have to be provided for all employees, we're really working across 4 generations, from baby boomers all the way to Generation Z. And everyone consumes data differently, and what Healthcare Bluebook does is they meet people where they are with it. So Frank, explain that piece first, and then I'll mention one other thing.
Yes, thank you, Rusty. So as you saw in our how diverse our client base is, it's interesting that some of our highest utilizers are actually manufacturing companies. So if the Schlumberger was up there, they're out on oil rigs, General Dynamics, Praxair. There are a number of really large groups that kind of fit that mold that you're talking about. So it's not just an app. The value of the app is it gives patients access to this information at the point of care. So you can be sitting in the doctor's chair and actually look at a proper facility and have that conversation in real time with your doctor. Healthcare Bluebook is also available online. We have a member support team that Rusty mentioned, so you can call in that high-touch concierge layer to help walk people through. There's also a live chat feature. You can email us. So there's all different types of communication modalities to get in touch with Healthcare Bluebook, and we just meet people where they are. In terms of, can I go back to one other thing? Okay.
Yes.
In terms of you were asking about other companies and competitors, things of that nature. There are other private or premium tools on the market. There's really nobody that does everything that we do from the standpoint of pharmacy, bundles, concierge, rewards, just the whole gamut of things that we provide. Our biggest competitor are the carrier tools themselves, and what we found is that most members don't know that they have access to the tool, number one. Number two, the carriers are not providing any kind of utilization reporting in terms of what members are using it. We provide all of those real-time analytics in terms of our members utilizing Bluebook on the web or on mobile, or we have all of that. What are the top procedures that are being searched? What areas are they coming from? All of that is very visible in real time. And then number three, the carriers are not showing any kind of return on investment. And number four, there's no ROI guarantee. So that's how we're different than the carrier tools.
Correct me, we also have a dedicated account manager specific to making sure Healthcare Bluebook is communicated to your employees the way they need to receive the information. So, and we're looking at the data to say, okay, what populations are engaging well? Which ones do we need to do a special mailer for on it? Do we, for those who are maybe ones that like using the phone, we can use a mailing to them to say, here's the number to use, put the magnet on the refrigerator. Whereas younger, you can chat, you can use your mobile. Again, it's different methods for different, but we think that there's not one solution that solves everything. You have to meet people where they are.
Other questions?
On your ROI slide, you list several, everybody from Miami-Dade to state of Florida. That's going to range significantly on their stop-loss coverage, because one of the examples you talked about was, after an employee reaches their out-of-pocket maximum, that bill is fully footed, by the plan. But, in our case, once they hit stop-loss, if our stop-loss is $1 million, state of Florida may not even have a stop-loss policy. So do y'all take that into account in your calculation here on ROI? Because as we shop stop-loss every year, that's going to significantly affect ROI if you were to lower stop-loss versus raise it. I was just curious if y'all took that into account.
I won't speak specifically to his calculation. I would say that even in the stop-loss contract, you have this year where stop-loss is working, but you also have that, what is that claim going to look like next year? So I bid stop-loss as part of my job, and the more risk controls you put in place, the more ways to mitigate large claimants, extremely large claimant, you're going to get concessions from the stop-loss provider versus not having some kind of control mechanism out there. Now, how do you validate that? How are you going to say a year from now there's going to be 2 or 3 spinal fusions that you're not fully aware of? Those are things you cannot predict because they're unknown futures. But to have this tool out there and to have reward mechanisms that steer you towards lower cost, centers of excellence, those types of things, you're going to have overall positive impact on that. But again, minuscule because stop loss in itself on catastrophic claims over that. But you're talking, just the potential of having those kinds of claims. And if you do have those claims, what are the programs you're going to do to help steer it? That's really what we're trying to touch on. This is really going for more those claims underneath those very large stop-loss levels, those procedures that are steerable. Instead of just going to the doctor's golf buddy or someone down the hallway, pull it up on your app and go, I see there's a $800 difference between the two. Any reason why I cannot go here? Doctor oftentimes will say, no, it's whichever one you want to go to, under $100, and save the county $800. Does that help? Okay, perfect.
Other questions? Frank, Rusty, thank you all so much. We certainly appreciate it.
Thanks for the opportunity.
Appreciate you all. It's, I think this committee would be wise to look at this when the new administration comes in to look forward. I think this is the way of the future. The industry is moving in this direction to where people can actually shop instead of just being taken advantage of you going to your doctor and them charging you for whatever. People are going to have to be more responsible. But I think by the incentives being offered, I know so many employees for Rutherford County that I talk to, they get nervous this time of month because they don't want to miss out on their Kroger points to get gas for $1, instead of $3. But there's an incentive there, and when you engage your employees into getting points, it makes a big difference, and not only for them but as well as the county. And some of those companies you're already doing business with are pretty impressive, from Disney World to Blount County. I know Blount County is one of the more progressive and Maryville counties that we have. So I know that somebody to look at. Sumner County's on your old plan. Looks like Blount's going on your new one, et cetera. But be smart in looking at that. Other business to come for us? Members?
Last thing.
Yes, sir.
I just want to thank Commissioner Allen, Commissioner Phillips. I don't know how the Insurance Committee is going to look next month after the County Commission meets, but I just want to thank you for your time here, your input, the work that y'all have done, your dedication. I appreciate it very much. Mayor Ketron, appreciate your input and your time. I will say that any time that I've had something come up or dealt with, you've always been available, and I appreciate it very much.
Well, thank you, Ed. Jeff, I'm not sure if you'll be coming back on the committee. If you want to, I'm sure that you'll make that known. I know that Ms. Allen and I will be exiting. Rhonda, any comments? Okay. Thank you very much for your service on this. It's been an honor and a pleasure to be your chairman for the last 4 years on this committee. Having retired from the insurance business, I understand insurance well, and people have a hard time with insurance because it's not a tangible thing. You can't put it in the bag, you can't bring it home and plug it in and watch it, you can't put it on and wear it and look pretty. It's just a piece of paper until you need it. And when you go in the hospital, your benefits are so important, and it's so important for this committee to represent your peers for Rutherford County. I want to say thank you for serving. This committee is so very important because that's one of the first things. First, when a person comes to work for us, it's on you. How much am I getting paid? and what kind of benefits do I get? Those are the first two questions that are asked. So I say thank you for all your hard work over the last 4 years. The new commissioners will be sworn in on the 31st next week. The administration will take over, and I wish each one of you good luck. Thank you for the department's work. You all do a great job for our risk management and making sure that we are taken care of and our employees are protected. So thank you very much. Anything else to come for us? If not, we'll stand adjourned. Thank you.